Professor Peter Siverovich, the immediate past president of the Heart Failure Association of the European Society of Cardiology, and currently the vice president of the European Society of Cardiology. And we have also Professor Giuseppe Rosano. He is president-elect of the European Heart Failure Association from UK. Professor Ovidiu Cianzo, he is executive committee of the Heart Failure Association, coordinator of the National Heart Failure Societies. And also we have Professor Shivid Bashir, he is a professor and chairman of Department of Medicine at Mississippi University from US. So the first session will cover important topics in the heart failure, recent updates, including pharmacotherapy and cardiogenic shock. So I'd like to invite my co-chairman in the first session to start the presentations of the first session. Professor Sriha. Professor Hussam Hassan, the chairman of cardiology department at Asyut University and is a board member of the Egyptian Society of Cardiology and the past treasurer of the Egyptian Society of Cardiology. Professor Gamila Nasser, the current secretary of the Egyptian Society of Cardiology, and she is also a chairman of cardiology department at Swiss Canal University. And Professor Muhammad Satiha is the chairman of cardiology department at Tantra University. So let us start the first session. You can introduce the first speaker, Professor Peter Siverovich. Professor Peter, do you hear me?
Yes, I can hear you. It is my great pleasure to be with you again. As we know, the Egyptian Society of Cardiology and also Heart Failure Working Group of Egyptian Society of Cardiology are extremely active and are having the lead position in the Middle East regarding heart failure. It is also important for me as the Vice President of the European in front of the is extremely important for European Society of Cardiology, and with the help of all of you and with your good ideas, I'm convinced that in the future we are going to have the much improved cooperation in a different field. And as Professor Magdi Abdelhamid pointed out, heart failure is an extremely frequent, extremely deadly, progressive disease which costs a lot to treat and to deal with. We are happy that we have in the last decade some new events and some new drugs in the field of heart failure. However, the heart failure treatment is still very complex. The 2016 guidelines gave us the basic treatment of heart failure, which is pretty solid and are giving us very good results. And when the drugs are not working, we are using the devices. However, what we are extremely focused on in the last few years are the comorbidities. Because treating comorbidities can halt the progression of the heart failure. and also may improve the treatment as well. One of the most important will be is obviously heart failure, and recently we will witness some positive, some nice surprises from the field of diabetes and anti-diabetic treatment, which gave us the possibility to get to the point that this treatment was proven in the field of heart failure without diabetes as well. It is what you are seeing now is PTX Salpêtrière, a hospital in France, and the students try to find the best treatment in cardiology for this young lady. However, nothing changed for 2 centuries, and we are still fighting to individualize our treatment in every particular heart failure patient in order to give him the best and prolong his life much longer. In that sense, SGLT2 inhibitors were very much into the focus in the last year because although they came as anti-diabetic drugs, they proved their efficacy in the field of heart failure as well. And they are introduced first as the drugs which will reduce the hospitalization for heart failure in many trials which are not designed to be heart failure trials. But the treatment of the patient with diabetes with anti-diabetic drug SGLT2 inhibitors. However, these drugs show very early that they may be used also in heart failure. And recently, we were delighted to learn from April Reviews that empagliflozin met the primary endpoint of first adjudicated cardiovascular death and hospitalization. Who practically were heart failure patients with very well defined characteristic of their heart failure. What was even better and which gave us also an optimistic outlook is that composite renal endpoint defined as end-stage kidney disease or sustained decrease in EGFR were also improved by a very highly statistically significant hazard ratio of 0.5. Having in mind the differences between the different types of heart failure, but also the possibility and the close connection between heart and the kidney. This is obviously one of the mechanisms in which empagliflozin and SGLT2 inhibitors are improving the situation of the heart failure patient. Even more, the quality of life was also improved in those patients, and KCCQ at 52 weeks was in the patient on empagliflozin comparing to placebo. These results were previously confirmed by EGYHF, presented at ESC meeting 2019, and the primary endpoint of cardiovascular mortality, heart failure hospitalization, and urgent heart failure visit was met with excellent statistical results and with a very early separation of the treatment curves. 26% of the relative risk reduction was extremely convincing. Cardiovascular mortality was also significantly decreased by dapagliflozin with 80% of relative risk reduction. Worsening heart failure were even better with 30% of relative risk reduction and the hazard ratio of 0.7, showing that dapagliflozin and SGLT2 inhibitors may give us the hope that will be extremely efficient in the treatment of the heart failure patients. As I pointed out, also symptom improvement in KCCQ with more than 5 points were also demonstrated in DAPA-HF. A few days after the presentation of Emperor Reduced in home, DAPA-HF and Emperor Reduced were both shown to have an excellent effect on several parameters which are tackling the heart failure evolution. This is obviously true also for KCCQ, as I pointed out. The surprise was to some extent that SGLT2 inhibitors were even better than ARNI in improving the functional capacity of these trials, judging according to the results of Emperor, Reduced, and Paradigm. Heart failure in its acute phase, it's something which is our next goal, and EMPA response acute heart failure, a small study in whom the primary hypothesis of the effect of empagliflozin in acute heart failure was not proved. However, the significant reduction in the clinical effects after the first 60 days after randomization was something which obviously are pushing us to investigate this indication furthermore. SGLT2 inhibitors, therefore, are recommended for reducing heart failure risk in the patient who has heart failure hospitalization in patient with diabetes and recommended EGFR of more than 30 milliliters. This, except for 2019 ESC guidelines for diabetes and prediabetes, is giving us the very important question, and this is to find out, is there any possibility for the preventive action of those drugs in the patient without over heart failure? We obviously are discussing the several treatment possibilities in heart failure. In 2019 early, we put clinical practice update on heart failure, and Heart Failure Association was very much worried about the postponing of the guidelines, but now we know that our 2021 guidelines will appear early in May of the next year. Obviously, the new treatment options are opening the new questions, and both SGLT2 inhibitors, as well as sacubitril valsartan, as well as VMPC1, and their positive effect in different subsets of the patient are giving us the possibility to see what will be the place of those different drugs in the algorithm of the treatment of heart failure. However, I think that we should stay critical on both or all three new treatment options. We know today that the GLT2 are reducing cardiovascular death and heart failure hospitalization in patients with heart failure with and without diabetes. The important point is the early activity of those drugs, which is practically witnessed by the early separation of treatment curves. The improvement in functional capacity is there, and the positive benefit in acute heart failure need to be further demonstrated. However, I'm not sure that besides the fact that we answered all questions, and we may say that there are some more questions to be answered, like the value of the combination of SGLT2 and sacubitril valsartan, then the effect of those drugs on vulnerable heart failure patients, elderly, frail, with multiple And obviously, what is the risk of the polypharmacy, different adverse reaction and interaction among these drugs? Dear friends, dear colleagues, I'm convinced that the SGLT2 inhibitors are the breakthrough in the treatment of heart failure. We obviously need to learn more about their effect. We obviously need to learn more about the exact, precise indication. But I'm convinced that those drugs, with everything we have so far, and we are also waiting for the results of omecamtiv mecarbil, which is going to be presented on November 13 during the American Heart Association meeting, that all these drugs will give us the possibility to treat our patient and better and give them the possibility to live longer. Thank you very much for your attention.
Thank you very much, Professor Peter, for this highly informative presentation. I will start by asking two questions, Professor Peter, regarding the clinical implications of SGLT2 inhibitors in the practice, based on the favorable results of the two important trials, EGYHF and the interval-reduced trial. How will these results change the practice and the potential implications on the guidelines in the near future? And how may the emerging clinical data affect the option of treatments in patients with heart failure? So, can you answer all these important points, Professor Peter? Professor Peter, do you hear me?
Could you hear me now?
Yeah. Did you hear the question, or should I repeat it again?
Yeah, I heard the question, no problem.
Yeah.
So, as I said, all these are very important questions. First of all, I believe that the task force for guidelines 2021 will have an easy task, because we have two big, statistically very powerful trials in whom the clear-cut effect of SGLT2 is shown. Therefore, I believe that this is going to be a very high class of evidence and also a very big level of evidence. Obviously, before we see the guidelines, nobody would like to say exactly what will happen, but it seems to me that we are, as I already said, witnessing the breakthrough in the treatment of heart failure. However, there are some controversies, and I'm convinced that all these controversies will be solved with the clinical application of the drugs. Being involved in several publications and in several of those trials, we see the great excitement all over the Europe. The people know that we have the new treatment strategy with a very effective drug, which is practically improving the long-term outcome in the patient with diabetes, which does not need the up-titration, which has a very mild side effect, and which is acting very early. So these four things is something which we need to take into account when we use this drug in the treatment of heart failure. I would like just to stress one more thing, and this is that we have at least 40% of our heart failure patients having no or no diabetes. For For these patients, these drugs are absolutely indicated. And I think that what will happen all over the world is that these drugs will become the standard of the heart failure treatment very early.
Thank you very much. We have another question from the floor, Dr. Ayman.
Please.
Can you hear me?
Yes, absolutely.
Okay, thank you first of all for your eminent talk. I'd like to ask one of the most challenges which we are facing in our daily practice is the diuretic tolerance. Okay, and one of the proposed strategies to overcome this problem is to add another diuretic to promote synergetic effect. But this will be on the expense of renal function and electrolyte balance. Do you think this relatively novel drug, especially with its smart diuretic effect and favorable effect on renal function, can add and value for solving this problem? Thank you very much.
Thank you very much for asking this question. It is very important for us to understand that recent trials, DAPA-CKD, and also the effect on which we have in embryo-reduced and DAPA-EGYHF, confirm the extremely positive effect of SGLT2 inhibitors in heart failure. As you know, at the beginning, in the first 2 weeks, we have a decline of the renal function, which is followed by the improvement of renal functions later, and extremely positive effect on the kidney function. Therefore, if we talk about the diuretic resistance, this is a little bit different area, and it should be solved at a different level. However, and the major question is, do I need to reduce the dose of diuretic when I give SGLT2? The answer, yes, we need to learn more how much adding effect of the SGLT2 diuresis is adding to the diuretics which patient already have. However, we also need to pay attention that the diuretic effect of SGLT2 inhibitors is much milder than for instance, the diuretics of the Helmets loop. Therefore, it is, I'm very happy that you asked that, because my last slide is showing you that even with these new drugs and even with the better capacity to treat patients, we need to improve our education, and we need also to take care of the art of medicine, which give us the possibility to apply the better treatment for every patient. Therefore, we need to learn more in one particular patient subset how SGLT2 are working.
Thank you so much.
Thank you very much, Professor Peter, for your participation and for your excellent contribution to our program, as usual. And we are appreciating your continuous support for the Egyptian Society of Cardiology. Thank you very much.
Thank you very much, and believe me, the pleasure was once again mine. Thank you.
Now we will move to the next lecture. The next lecture is about novel treatments of heart failure in 2020 by Professor David Butler from the United States. Professor David Butler is Patrick Lamb Chair in Cardiovascular Research and Professor and Chairman of the Department of Medicine at the University of Mississippi Medical Center in Jackson, Mississippi. He is also a professor of physiology. He has numerous publications, more than 650 publications, and he is an editor of several journals. Professor David Butler, you are with us?
Great. Thank you very much. Can you hear me?
Yes, we hear you clearly. Please
Great.
can you share your story?
It's absolutely a pleasure, and I very much appreciate the opportunity to be presenting in this forum. I will are my disclosures, and I took a
Please open the view streams.
uh, can you see it now?
Yes, it's clear. We hear you and we see the screen.
Yeah. So pretty much all the drugs that I will be talking about, I'm a consultant in those clinical trials. So please keep that in mind. And again, I have about 15, 18 minutes, so I will only put up some heart failure with reduced ejection fraction, and we'll talk about drugs. I will not be able to cover heart failure with preserved ejection fraction or devices, but I will be very happy to get all the answers. So the topic is to talk about the novel drugs, and the novel drugs, while paradigm HF and angiotensin receptor neprilysin inhibitor is not really a novel drug per se. This trial came out in 2016, so now we already have had 4 or 5 years of experience, and the fundamental paradigm shift that this trial brought was that we not only started working on the bad side of the neurohormonal activation with the sympathetic nervous system and the renin and aldosterone system, but also while we are attenuating the bad neurohormones, there was a mind shift to accentuate good neurohormones, so do more of good things, not only less of bad things. So that was the whole concept, and as we know, this trial was very positive and reduced cardiovascular mortality and heart failure hospitalization. So what have we learned more about this agent subsequently? So Pioneer HF that came out last year and basically said that if you start this drug in the hospitalized patients who are stable, so they've been in the hospital for about 24 hours and they're not hypotensive and not on isotropes and IV vasodilator, but they may still be needing IV diuretic therapy. But you know, so this is really a true heart failure study. We started, you can see that just 8 weeks, I mean, very short term after the discharge, just in 8 weeks, there was a substantial reduction in the risk of readmission. And then the other study that came out with a paradigm HF or Valsalva sacubitril was the effect on cardiac remodeling. This was a study that looked at basically the changes in LV volume and dimensions and ejection fraction after we start. There was no control arm. This was a pre-post study, and as you can see, that within 1 year we were talking about an improvement in ejection fraction in the 8 to 10% range and reduction in LV volume in 12 to 15% range. So a lot of positive data that we have seen with valsartan sacubitril, and it continues. So the reason why I took time to highlight these studies is not that we don't know about valsartan sacubitril, but in the interest of all the new data that we are seeing, that we don't underestimate the benefit of valsartan sacubitril and not fall into the trap of not moving our patients from ACE inhibitors and ARB to valsartan sacubitril whenever it is available and it is tolerable. Now, Dr. Zaferovich already showed the top line results from NAPA-HF and EMPEROR reviews, and what I find interesting is how overlappingly consistent they were. They first started moving separate early in the course, and both trials showed about a 25-26% relative risk reduction. But while I'm a heart failure transplant cardiologist and focus on heart failure, what I really want to take a minute to highlight is the plethora of data that we have in patients with type 2 diabetes and how these drugs are preventing heart failure. And while we are all focused on treating heart failure, really the place to start these drugs is in type 2 diabetic patients. It doesn't matter whether they have history of atherosclerotic cardiovascular disease, which is risk factor. There is substantial prevention of heart failure as well. So along with treatment, maybe we can go to some prevention as well. So what else do we have other than SGLT2 inhibitors and angiotensin receptor neprilysin inhibitor? Well, there comes this whole debate whether worsening heart failure is an entity that should be dealt with by itself. So what is worsening heart failure? Well, you have de novo heart failure, new onset heart failure, and you try to then treat the people with whatever ACE inhibitor, beta blocker, MRA, RD, and then they tend to sort of get a little bit stabilized. They are in the outpatient setting. They may or may not have some symptoms. And after being stable on medical therapy, they start becoming unstable again, and you have to put them in the hospital and diuresis them. So the question is that when you break through already good enough and just forget about it, or this is something else going on. But what we are learning from data on hospitalized patients is that even if you say that there is really no new pathophysiology, there is certainly change in prognosis. Once you develop worsening heart failure on top of outpatient medical therapy with which you used to be stable at one point but now are not anymore, we're talking about a 30% 1 year mortality. So at least the prognosis gets worse. So that was the reason to focus on the Victoria trial that Ronisi got, which acted on a completely different pathway of launching techniques in a nitric oxide cyclic GNPPH signaling pathway. Again, if somebody is interested in the mechanism of action, we can go into that in the Q&A. But the bottom line is that as opposed to the other contemporary trials like Paradigm HF, HF, Victoria trial had a much sicker patient population, much higher NT-proBNP level, and these were the primary endpoint. It was a 10% relative risk reduction, the primary endpoint of cardiovascular death or heart failure hospitalization. So some of us may have a reaction to say that if you look at GAPA-HF and Emperor-reduced and Paradigm HF, you're looking at about 20-25% relative risk reduction. This is only 10%, and is that a big deal? So I want to put this into a little bit of a different perspective, and the different perspective, and I apologize if it's a really busy slide, is that remember 10% risk in a the high risk group may exist out a little bit more in Egypt. So what I have done here is all of these four trials, and let's look at the comparator arm placebo 1 year event rate. And one can see that the annualized event rate in Paradigm HF was 13, and DAPA-HF was 15, and Emperor-reduced was 20, and then Victoria was almost 40. Really sick patients. So what did that 10% relative risk reduction absolutely mean in terms of absolute risk reduction? And one can see in Paradigm HF, the absolute risk reduction for the primary endpoint was 2.7%, and DAPA-HF was 4%, Victoria was 4.2%, and Emperor-reduced was 5.2%. So all of a sudden, if you look at it from a different perspective, these results start looking a little different. Also, what we found in Victoria is that if you look at the lower 3 NT-proBNP quartile, their benefits were actually pretty similar to GAPA, Emperor, and Arni, but the sickest of the sick patients were the ones that were not benefiting. And indeed, when looked at as a continuous variable, up until NT-proBNP of 8,000, there was a cardiovascular mortality benefit differentiated. So I'm sure that the guidelines committee will have a lot of discussion about what to do with it. This is sort of a schematic of heart failure trajectory. At some point, if you look at the left of the curve, we don't have heart failure. We slowly start developing risk factors, and then you develop heart failure, your risk goes really high. However, the risk, while it's very high, you run multiple therapies. So people get started on medical therapy with drugs and devices, and their risk comes down, but it never comes down to being normal. And then you become stable. But then that's when you start running into problem again, hospitalization, shortness of breath, edema, IJVP, and this is what we call it worsening heart failure. And the idea here is to give effective therapy so that you go back into the residual heart failure risk bucket as opposed to progression into advanced heart failure, transplant, LVAD, palliative care, and all that kind of stuff. So this will be interesting. So then the next big trial which is coming out is the use of IV iron. We know from many trials in the past that IV iron is associated with making you feel better and do more. So NYHA class symptoms and 6-minute walk test improve substantially. The question is, what is the impact on outcomes, hospitalization, mortality? So the top line result of the AFFIRM HF trial was presented in the news release. So this was about 1,000 patients with acute heart failure in a it turns out that the trial from what we can learn at the top line narrowly missed the p-value. So the p-value was almost significant but narrowly missed. However, the trial was also affected by the COVID-19 pandemic. And then when the investigators went back and looked at a pre-specified analysis of pre and post-COVID, it sounds like that the pre-COVID results were positive. So I think we will learn a lot about that at the American Heart Association. Just keep that in mind. And then the Galactic trial, also the top line results were positive, but not as positive, if you may. And we'll learn more about that at EGYHF as well. But I would want to take the last 2 or 3 minutes to conclude by saying that we're living in this era of polypharmacy where there are multiple drugs, and the question is, what is the additive benefit? When you keep adding more and more medicines, are we getting some benefit? Are we getting full benefit? Are we getting synergistic benefit? So that was looked at by the colleagues. This came out in Lancet, and the question was, not as compared to placebo. If you're on good medical therapy with ACE inhibitor, beta blockers, and MRA, what is the benefit do you get if you add SGLT2 inhibitor and switch ACE inhibitor to ARNI? And what they concluded was that you're looking at extending the life by almost 6 years. So this is serious if we can continue to improve medication. The other question also is that as a clinician, sometimes I have a lot of inertia that life just gets busy. You see a patient and you just say, you know what, I will, maybe change the medication. I know the medication needs to be changed. Then maybe when I see you in 3 to 6 months, I will go ahead and make the change. But what we are learning is for the Kaplan-Meier and EGYHF was achieved on day 28, and statistical significance in emperor reviews was achieved in day 12. So there are these benefits that accrue relatively very early, whereas what happens in real life is that we take months and years in order to optimize the medical therapy. So I would say that unless and until there are insurance, costs, tolerability, all of those real life issues that are there, and we will take care of that on the bedside. But in reality is that we now have four therapies, ARNIN, not ACE inhibitor. And again, if cost is an issue, availability is an issue, ACE inhibitors are great drugs. But there has to be a good reason not for the patient not to get ARNIN. But at this point, ARNI and beta blocker SGLT2 combination is the way to go, and the sooner we give it, the better it is. But the life is getting much more and more complicated, and there are all these other options with drugs and devices that are also coming. So good time for heart failure patients, but how to implement this is our challenge as time. Again, thank you so much for giving me the opportunity to present.
Thank you, Dr. Javid, for this very interesting presentation. The data from SGLT2 inhibitors as add-on over the standard therapy for heart failure will change the next guidelines for heart failure treatment. Do you think the class of recommendation according to the available data will reach class 1 or it will be just class 2B according to the current data as you think from what we have till now?
I mean, I obviously don't know what the guideline committees are going to do, so one can only make a prediction based on what the rules or the past precedence is. And the rules are that it should be at least 2 clinical trials showing consistent results, and the results should be really positive, but not sort of borderline positive. So if you look at the Victoria trial, that's a little bit of a problem, right? There's only one trial, and the p-value was sort of 0.02 or 0.03, something like that. But if you look at SGLT2, you have two trials, and both trials primary endpoint was less than 0.001. So I would not be surprised if it's a class one recommendation, but we'll see what the guidelines do.
Professor David, this is Magdi Abdelhamid. Asking about polypharmacy now, we have many drug classes. We have the EGYHF, we have dapagliflozin and SGLT2 inhibitors, sacubitril/valsartan, So do you think that individualized treatment or precision medicine in patients' heart failure will be the next step because which drug to start, which drug to add? So what do you think about this?
Yeah, so that's a really great but complicated question. So let me just give you a very quick some thoughts from my perspective. So one is when we use the precision medicine, one interpretation of precision medicine is targeting biology with the drug mechanism of action. We are not there yet right now. So I don't think that in the next, at least in my career, in the next 5 or 10 years, that's what we will be doing. So there's a lot of promise with the omics and proteomics, genomics that we might get there, but I don't think that that's going to happen soon. So then the second personalized medicine is obviously based on tolerability, blood pressure, heart rate, fasting, creatinine, and that's common sense medicine, and we will continue to do that. The third issue is the sequencing issue that you brought up. So my personal bias is, and this is absolutely my opinion, and my respected colleagues may completely disagree with me, but my opinion is that remember the sequencing is a historical construct, not a biologic construct. There's no biologic reason to give ACE inhibitor first or MRA last or RNA or whatever. I mean, this is just in the 1980s we developed some drugs, in the 1990s we developed something else, in 2000 we developed something else. So there's no biologic rationale. So I'm actually not very hung up on the sequencing. I just think that at least low doses of all four drugs, the sooner we start, the better we are. And then the last thing is that in my mind, personalization starts after quadruple therapy. So, if you have persistent high, hypertension, or you're not able to tolerate one drug. So giving super high levels of nitrogen, persistent high heart rate, you can give, ivabradine, IV iron deficiency, IV iron. But I think all of those things come after what we're calling foundational therapy with the four drugs can be given. And then the last comment that I will make is that there will be a robust discussion in the scientific community whether we are at a point where we should now look at subgroups within trials to make our recommendations to personalize that this group gets to benefit more, that group gets to benefit less. That's a really dangerous slippery slope, but sheerly on the basis of the number of drugs and cost, we may end up doing there. I have no idea how the science will evolve.
Thank you very much for excellent lecture. I'm Hussein Andil, Professor of Cardiology at Cairo University. With these advances in pharmacotherapy, knowing that device therapy has been an integral part of heart failure treatment for the past several years, and knowing that most of these trials, if not all of them, have been done without ARNI and without drugs like SGLT2 inhibitors, what would you think? Because in Egypt it's very expensive to have all these devices. You think these trials that we've done on these devices will stay positive with current advances in pharmacotherapy?
So you're asking two questions in one, and really important question. I mean, it's not about Egypt. Even in the United States, most of the people don't get devices because of cost and insurance issues. I mean, this is a global problem, and devices are very expensive. So the first question is that part of the problem is that we take too long to put people on good medical therapy. I mean, that's the idea. Devices is yet another reason that if we can see the patient soon, maybe every week, every other week, and just start following these patients fast, we know, and I showed you some data today, that RD has significant impact on reverse remodeling. We know that beta blockers have significant effect on reverse remodeling. We know that MRAs don't have a significant effect. And there are no good remodeling studies with SGLT2 inhibitors come will be presented soon, but I won't talk about them. But the bottom line is that if you were to give good medical therapy, there's a sizable proportion of to ejection fraction is still 34%, except that you have lowered the risk of sudden cardiac death to a point that perhaps the defibrillators don't lower it anymore, or even if they lower it, you need to give way too many patients defibrillator that it's not cost effective. So the number needed to treat in the past used to be 30, maybe now it's 100. So I don't know the answer to that question, obviously, but that's a really, really, really important question, and I think we should evaluate the role of devices on contemporary modern medical therapy. Very good question. I don't have an answer.
Thank you very much, Professor David, for your great contribution to our program, and we are looking to see you in person in Egypt when life is back to normal. Thank you very much.
Great, thank you.
Dr. Rosano, you get us? Dr. Rosano is a professor of cardiology, consultant cardiologist at St. George.
Dr. Rosano is not online.
He's not online.
I do have the honor to introduce the next speaker, Professor Ovidiu Chantal from Bucharest, Romania. Are you here? You hear us, Professor? Are you ready to join us?
Professor Ovidiu.
Professor Ovidiu.
Yes, of course.
Hello, sir.
Hello.
Hello, greetings from Cairo, and we are very pleased to have you with us in the Heart Failure meeting this year, and we're very pleased to have to hear your presentation today about critical medicine, about cardiogenic shock, and Professor Ovidiu, we're glad to see you here to share with us this meeting. You're a professor in the Emergency Institute for Cardiovascular Diseases, Bucharest, Romania.
I'd like to add that Professor Ovidiu is the Executive Committee of the Heart Failure Association. He's the coordinator of National Heart Failure Societies. We are delighted that you are joining us today, Professor Ovidiu. Good to see you.
Thank you so much. First of all, I should say thank you so much, and I'm deeply indebted to the Egyptian Society of Cardiology for inviting me, and particularly to Professor Nadia El Hamid, who actually is my co-chair for the Acute Heart Failure Committee. And my task for today is to talk about cardiogenic shock, and you know very well that cardiogenic shock represents the most severe form of acute heart failure syndrome. Actually, there is no uniform definition for cardiogenic shock, and several randomized clinical trials include anti-dynamic data for cardiogenic shock, and recent European Society of Cardiology guidelines, and many other cardiogenic shock definitions include hypertension, defined as systolic blood pressure less than 90 or need for catecholamines, to define cardiogenic shock. However, it's very well recognized that in shock, compensatory mechanisms may preserve blood pressure through vasoconstriction, while tissue perfusion and oxygenation may be significantly increased. Thus, hyperperfusion is not always accompanied by hypotension. Based on this consideration, EGYHF proposed recently a new definition for cardiogenic shock, and it sounds like cardiogenic shock is a syndrome whereby a primary cardiovascular disorder in which the low cardiac output depends on life-threatening state of tissue hyperperfusion with varying tissue oxygen metabolism, which determine its severity may result in heart rhythm dysfunction and death. The new definition of cardiogenic shock proposed by Heart Failure Association fits very well to pathophysiology of cardiogenic shock,
And the pathophysiology of cardiogenic shock includes several unique but overlapping components to be considered as initial cardiac insults that decrease cardiac output, central hemodynamic abnormalities, microcirculatory dysfunction, inflammation, and multi-organ injury. Although all these mechanisms may be considered as temporal stages of cardiogenic shock, each may occur simultaneously, and the magnitude of initial cardiac insult or early application of therapies may either mask or delay all these stages. The occurrence of multi-organ dysfunction and microcirculatory dysfunction, and actually microcirculatory dysfunction is the main contributor to the organ failure of cardiogenic shock. Both trends of very good prognosis, and in these manuscripts, the number of dysfunctional organs was associated with increasing in hospital and secondary mortality. Cardiogenic shock is not only acute myocardial infarction, and actually there are several etiologies responsible for cardiogenic shock, and we are seeing a large diversity of etiology, and coming from acute myocardial infarction to mechanical complication with cardiac muscle rupture, to prosthetic valve dysfunction, and apparently right ventricular dysfunction. And it's crucial to recognize the etiology in the early stage of cardiogenic shock. In terms of classification, one of the first classification of cardiogenic shock proposed by Hoffman was based on stages of severity and includes three stages: precardiogenic shock, classic cardiogenic shock, and refractory cardiogenic shock. And the recognition of precardiogenic shock, and recently there are 10 or 20 very good manuscripts describing this clinical entity, precardiogenic shock, maybe particularly challenging in a certain category of patients like Afro-American patients using concomitantly using alpha-1 stimulants, patients with long-term treatment with beta blockade and massively obese patients. Recently, the state classification has been used in clinical practice, and it's very, very easy to use for any type of clinical settings. And recently, this type of classification, state classification, was validated in pulmonary care unit, in cath laboratory, and even in emergency department. And recently, we have two very well designed research showing that this type of classification correlates with mortality in pulmonary care unit, and there is an increasing mortality risk for each stage of severity of cardiogenic shock. Actually, the final picture of cardiogenic shock is more complicated, and it shows an overlapping between these two classifications. In terms of risk stratification, there are several risk scores for mortality due to cardiogenic shock, and I will summarize here only the risk score in hospicial era, and we are talking about predicting short-term mortality, and we should use cardiac shock and the EABP shock to risk score. And we have a recent score for predicting patients at risk of developing cardiogenic shock, and this is only risk score. And one weighted score, it's quite complicated because it's including 17 variables. It's ECMO safe risk score, but it's used quite common in intensive care unit because it's predicting mortality for patients in patients in very severe patients of cardiogenic shock and may distinguish between true indication and futile situation for this type of patients. Recently, proteomic research may further assist to understand the pathophysiology of cardiogenic shock and may improve risk stratification in this type of patients, and why not may provide an opportunity to treatment. Recent research study identified a complex of four protein, TC4 protein, pathogenic shock 4 protein, and this TC4 protein was associated to multi-organ dysfunction, systemic inflammation, and immune activation. During the early hours of cardiogenic shock, changing in expression of TC4 protein identify patients at high risk to die. Recently, TC4 risk score improved the risk stratification in patients with cardiogenic shock, and accuracy of this risk score was beyond the VABP shock and cardiac shock risk score. That's why recently the European Heart Journal was presented this type of editorial, and the fact is highly suggestive, no level of signature of cardiogenic shock. Concerning cardiogenic shock management, I would say that the data from clinical trials are very scarce because till now in 2019 only 1,600 patients were enrolled in clinical trials, and most of our data are coming from retrospective analysis of large trials in any type of cardiogenic shock. Specifically for cardiogenic shock, we have data from only 1,500 600 patients enrolled in ICU or CCU. For sure, nothing changed. Cardiogenic shock management should start as early as possible, and the philosophy behind this is just to prevent or stop systemic inflammation and multi-organ dysfunction. Management should start as early as possible in pre-hospital settings, and physicians should stabilize oxygenation, circulation, and treat the underlying etiology by monitoring vital signs. One important issue is related to identification of cause, and we are talking about the ischemic cause and anti-arrhythmic causes of the causes. Ischemia is represented by a large acute myocardial infarction, and the best treatment is revascularization. And we have some very good trials showing the benefit of revascularization in patients with cardiogenic shock. First of all, we have a shock trial showing that an invasive strategy compared to initial stimulation can have significantly benefit in terms of all-cause mortality at 6, 12, and 60 months, and this benefit was strongly consistent across several subgroups as age, sex, and ethnicity, and type of ACC, presence of absence of diabetes. We had PCA trial showing no benefit from routine use of VABP in patients with cardiogenic shock. And of course, we have the most recent culprit shock trial showing that the culprit-only strategy compared to immediate multivessel PCI is resulting in a significant reduction in so-called mortality. One important point to remember, management of underlying cause is crucial, and without having etiological improvement, we probably came back 30 years ago. And again, treatment in acute myocardial infarction is early revascularization, mechanical complications, early surgery, prosthetic thrombosis, is cardiac surgery, and in patients with the right ventricular dysfunction secondary to rupture, pulmonary embolisms, thrombolysis, or surgery. Particularly in stance, it's related rupture secondary to acute myocardial infarction. And inside of EGYHF, we consider that early use of mechanical circulatory support may bridge patients until a decision can be made as to delaying transplantation or palliation after a first discussion inside of multidisciplinary team. Several studies suggested that early use of VA ECMO in patients with post-infarction ventricular septal rupture provides hemodynamic stabilization and potential to reverse multi-organ failure, and delaying surgery may promote the healing process and fibrosis of the body of the septal rupture. In terms of medical therapy, vasoactive therapy, more than 80 to 90% of patients with cardiogenic shock will receive vasopressor or immobilists. And we should remember that vasoactive medication may restore hemodynamics, but at the cost of increasing myocardial consumption and arrhythmogenic part. Therefore, the general recommendation and the heart failure guidance recommendation on vasoactive is to avoid remission of specific trials. In these settings, we are just conducting trials in cardiogenic shock, general cardiogenic shock of any case. We have one of the few trials is Optima CC trial, including post-cardiogenic shock, comparing epinephrine versus norepinephrine, and in these patients, norepinephrine was associated with a significantly lower rate of refractory cardiogenic shock. It's one of the very few clinical trials, real clinical trials in these patients with cardiogenic shock. That's why norepinephrine should be used as first-line vasopressor in patients with cardiogenic shock to sustain contribution pressure. However, there is an inverse relationship between the number of dose and duration of vasopressors in cardiogenic shock. Particular attention to levosimendan, which is useful in patients already on beta blocker and in patients with right ventricular dysfunction or severe pulmonary hypertension. Discussing about mechanical circulatory support, this had an emerging role in patients with cardiogenic shock, especially in patients refractory to rhinotox and vasopressor, and they can be used as bridge to precision and bridge to recovery, reevaluation, or transplantation in these settings. Mechanical circulatory support may exist in several configurations, right or left side ventricular support. And we should notice that in spite of improving cardiac output, mechanical circulatory support associated with severe complications like bleeding, renal dysfunction, vascular complication, and this type of complication may counterbalance beneficial hemodynamic effects. And further research recently is needed to establish a better risk-benefit ratio for this type of metastasis. This is of utmost importance in a particular group of patients like elderly, patients with long duration of cardiogenic shock, or patients with multiple comorbidities. There are several protocols used to initiate or to wean patients at mechanical circulatory support, And it's also educated opinion when using mechanical circulatory support is to have invasive assessment of hemodynamics and clinical science, echocardiography, blood uptake, and again, invasive assessment of hemodynamics may guide titration of this type of intervention when we have mechanical circulatory support. I should say some words about the trend of using the different type of mechanical circulatory support. And in this manuscript, we see decreasing the trend of using the intraorbital implant concomitantly with increasing using of Impera, ECMO, and Hamilton. And I should say some words about intraorbital implant. In my hospital, we are using a lot of intraorbital implant, especially in patients with acute myocardial infarction in cardiogenic shock with severe complication. And although providing only modest benefit in patients with cardiogenic shock, EDP may be very effective in this type of patients with severe complication by diastolical implementation of flow and decreasing artery. We should pay attention to correct positioning and synchronization, which may dramatically improve the results. Peripheral VA ECMO can be associated with progressive distension, pulmonary congestion, and this is a very nice case showing ventricular arterial ECMO, and combination between Impella and ventricular Impella, it's a transaortic pump, and the VA ECMO showing decongestion of left ventricle. Impella is a very good device, it's very easy to implant, it takes less than 20 minutes in cath lab, and there are some warning signs, and recently European study showed that no mortality benefit compared to VAPT, but more complication. These results were confirmed in two recent American studies, showing that Impera was associated to significantly higher rates of complication, even more, higher rates of in-hospital investment compared to VAPT. Although all these three studies are retrospective studies, and these studies were proposed in May, they only limit randomized clinical trial design and should wait for the definitive trials and ECMO, Euro ECMO score, and the ACLS shock trial showing a direct comparison between Impella, ECMO, and VAPT. In the absence of definitive randomized clinical trials, we believe that should consider this type of studies, and they represent a safety signal rise against clinical complications related to the selection of appropriate device for these patients. Expertise and facilities are key issues when treating patients with cardiogenic shock, and the model analog to primary PCA pathway has been recently proposed by the American Heart Association and Heart Failure Association to facilitate optimal care and the care coordination and minimize time waiting in centers. This model consists of a network between several satellite centers doing a big split and central hub centers which have multidisciplinary cardiogenic team on-site cardiac surgery and advanced mechanical circulatory support there 24 hours. And other important progress in the management of cardiogenic shock was standardized in base care for patients with cardiogenic shock. And recently, the National Cardiogenic Shock Initiative designed a shock protocol and organized them to mutually agree to treat patients according to the best practice. This protocol included right heart catheterization with pulmonary artery catheter measurements and implanting mechanical circulatory support based on hemodynamic criteria like cardiac power index less than 0.6 and pulmonary artery susceptibility index less than 1. This initiative suggested that protocol-based strategy is deeply productive, and the overall adherence to the protocol may be associated to improving outcomes. In conclusion, I would like to say that cardiogenic shock represents no severe form of critical failure and mortality remains unacceptably high. Early recognition of cardiogenic shock is crucial of the use of pre-shock status. Risk stratification is based on uptake, microcephaly dysfunction, several modifiers including cardiac arrest and hemodynamic data. MCS utilization is balanced by stage of severity and complication. Cardiogenic shock network with cardiogenic shock centers and using standardized protocols may potentially improve survival and continuously lead for new randomized clinical trials. Thank you so much.
Thank you very much, Professor Ovidio, for this amazing presentation. We hope the next presentation will be in Cairo and everything will be fine in the whole world. Thank you very much. I have just one question. I'm asking about the fragmented QRS complexes. We had some research work in Egypt for that, and maybe it's a relatively cheap, non-invasive tool to predict the incidence of cardiogenic shock as well as the mortality. What's your opinion? Can we rely upon that?
Can you repeat the question?
The fragmented QRS complexes. It's some sort of non-invasive tool that you can depend or you can we rely upon it to detect, to predict the mortality in cardiogenic shock.
We
It's
can
just an
use that
easy
one.
tool.
Yes. I think in patients with ischemia, QRS fragmentation is an excellent tool for sudden death. But as you know, in cardiogenic shock, most common way to die is pump failure. We can integrate QRS fragmentation, but until now there is no any result in QRS fragmentation. I should remember that beyond the beautifulness of the risk score, and all these risk scores are beautiful, we need prospective validation. And unfortunately, only the ADP shock 2 risk score and cardio shock score are validated in clinical practice and in different clinical settings. So we should wait for QRS fragmentation. But agree, it's a marker of sudden death in different type of patients, and especially in patients with myocardial infarction and pulmonary ischemia.
Professor Ovidio, regarding the pharmacological treatment, unfortunately, we are limited with the use of inotropes and the vasopressors with the hazards of using these drugs, and the mortality rate is high despite of using the maximum doses. So, norepinephrine compared with dopamine and inotrope hydrocyclidine in patients with Takotsubo was associated with favorable outcome. So what is the ideal inotrope and the vasopressor in such cases, especially in centers who are not, don't have the facility to use devices such as Impella? What do you recommend regarding the pharmacological treatment?
I think that levosimendan, which is an immunomodulator, it's an excellent drug, but it's quite expensive. And we are using in my hospital a lot of levosimendan, but even without those, levosimendan is associated with hypertension, and very commonly we are giving levosimendan and norepinephrine. But why not? The vitamin is a very good drug. In patients with cardiogenic shock and low systolic blood pressure and multiple signs of hyperperfusion, we should not do philosophy that IBI not to increase oxygen consumption or immunogenic partnership. We just should prevent life-threatening complication of like heart failure. Why not? We should give the vitamin. We should do very wisely the vitamin. But this is other story. We cannot stop using these drugs. And I think that in clinical practice, we should start with the vitamin. In patients with acute myocardial infarction and a large amount of standing myocardium, probably levosimendan is better. In patients with pre-shock, with increasing vasoconstriction, compensatory vasoconstriction, levosimendan and the norepinephrine would be an excellent choice. We should not forget mirroring. Okay, we have the data showing that mirroring is increasing mortality in patients of ischemic etiology. But in other category of patients, and the patients with right ventricular dysfunction, mirroring is a regular option. We should not forget vasopressin. In patients, we are talking now what is, sorry for navigating, what is refractory cardiogenic shock, if it's a mention of the number of vasopressin medication or quantity of medications, the doses of medication, and actually we are using the norepinephrine equivalents. But in patients with, let's say, migraine, and when we observe vasodilation using by the mineral association with vasopressin, it's also an excellent option. So finally, I would say that we should not renounce the vitamin. The vitamin is a very good drug. We should stay near patients to monitor the effect of this therapy. Norepinephrine, it's an excellent vasopressin drug. Then we have money, and unfortunately, also in very rich countries, levosimendan is missing, because levosimendan is an excellent for patients, and beta blocker patients with hypertension dysfunction, pulmonary hypertension, or with myocardial stenosis. And we should stop here, because epinephrine is not anymore considered as inappropriate patients with cardiogenic shock and dopamine. Dopamine, we should not be, this drug should not be used anymore for treatment of patients with cardiogenic shock. I hope that answered your question.
Great. Thank you very much, Professor Ovidio, for your active participation and for your excellent contribution to our program. Thank you very much.
Thank you. Dr. Rozan, you hear us?
Yes, very well.
Welcome you. Thank you for being with us. Welcome from Egypt, from the Institute of Cardiology, the World Group of Heart Failure. I would like to introduce you to the audience. You are a professor of cardiology, consultant cardiologist at St. George Hospital in Glasgow University of London. He's a board member of the National Heart Failure Association, the chairman of the Education Committee of Heart Failure Association. He currently serves as an expert in the area of cardiovascular medicine, the European Assessment Office at the Italian Drug Agency. Is a core member of the Cardiovascular Working Party, the European Medicine Agency. Dr. Rozan will talk about the functional myocardial heart failure and how to manage it by drugs, devices, or surgery. And we are interested to hear from you when to use drugs, when to shift to device, and when to shift to surgery.
I'd like to add that Professor Rosano is currently the president-elect of the Heart Failure Association. Welcome, Professor Rosano.
Thank you, Magdi. And I mean, I'm so sorry I cannot be in person with you. I hope that we will be able to meet together soon. And it's a great pleasure and an honor to be part of this meeting today. We are very pleased to have the Egyptian Society of Cardiology and the Egyptian Working Group of heart failure very well represented within the HFA, with Magdi Abdelhamid being a very prestigious member of our board. So without any further ado, let's start talking about functional regurgitation. And what you see here is still a very old but still very present slide. These were one of the very few first cases that underwent the Alfieri procedure when I was working with a group in Milan. And that was where I should say everything started, because the Alfieri stitch operation for sure changed the landscape of functional regurgitation. But what is the functional mitral regurgitation? Is mitral regurgitation that is due to papillary muscle displacement with an increased feathering of the mitral leaflets, and with the closing forces that therefore are reduced because of the impaired contractility. And it's also associated with an annulus dilatation, and sometimes in patients with left ventricular or induction of abnormalities by the left ventricular dysynchrony. We have to say that there is a difference between the conditions where we have a left ventricular dysynchrony that is associated with left ventricular block, where CRT often restores, at least in part, the functional mitral regurgitation, and the mitral regurgitation that occurs in patients with progressively dilating heart, with increasing tethering forces that overcome the closing forces of the valve. But also, we have to understand that the functional mitral regurgitation is part of the vicious circle that starts with LV dysfunction and dilation, induces the regurgitation, then, of course, further it delays the left ventricle and the left ventricular dysfunction, and therefore the mitral regurgitation worsens and starts this vicious circle. So, in theory, if we stop at some stages this vicious circle, we should be able to improve conditions. But first of all, we need to see and look what is the prevalence of functional mitral regurgitation in patients with left ventricular dysfunction. And we can go into the different aimed treatment, but we should say that around 50% of our patients with left ventricular dysfunction, in some cases 70%, have some functional mitral regurgitation. Now, can we do something with drugs? I mean, drugs, of course, work in patients with left ventricular dysfunction, but we can see that the mortality in patients with left ventricular dysfunction varies according to the presence of mitral regurgitation. Because if we take patients with significantly depressed left ventricular function, so less than 25%, we can see that in those with severe, but even in those with moderate mitral regurgitation, the mortality is pretty high. It's nearly 60% after years. So there is a need, despite the presence and despite intensive medical therapy, to do something for this balance. And we also know that the severity of the mitral regurgitation, regardless on how we assess, if we assess the regurgitant volume or the regurgitant orifice affected, then we can see that the greater the degree of the regurgitation, the greater is the mortality. So in heart failure with severe functional mitral regurgitation, the mortality is very high, so, and despite medical therapy. Now, the guidelines, the last guidelines that we have from the European Center of Cardiology Heart Failure Association, they say that the effective medical therapy is effective in reducing the remodeling of the left ventricle and may reduce the functional mitral regurgitation. But also, they also say that the combined valve and coronary surgery should be considered in symptomatic patients with left ventricular dysfunction and with coronary arteries suitable for revascularization and with evidence of lipidity. And surgery is recommended in patients with severe regurgitation undergoing coverage with a left ventricular ejection fraction of 30. But these guidelines, I mean, despite being 4 years ago, I mean, seem a long time ago. Because in the same time, and in the past 10 years, we have seen that are used for the treatment of mitral regurgitation, the mitral clip that has evolved over time, the cardio, neoport, the cardio, and most of them, the majority of them, apart from the carry-on device, basically they tend to do the same thing that the Alfieri stitch operation does. So basically, stitching the two valves, the two leaflets together leads to a reduction of the orifice. Of course, it leaves a double orifice, often with some degree of regurgitation. And this is what the different devices that we have, they tend to do. So basically, they tend to clip two valves together, then thereby reducing the regurgitation. Now, the guidelines in 2016, we did not have any significant evidence on the mitral clip, and therefore we said that the percutaneous mitral valve intervention may be considered in order to improve the symptoms and quality of life. But surprisingly, after the guidelines came out, 2 years after, I should say 1.5 years after the guidelines, we had the results of the mitral EGYHF. Basically, is a study that was conducted in patients with functional mitral regurgitation that did not show any difference between people receiving intervention with a mitral clip and the control group. Fortunately, after the mitral EGYHF, we had another trial. It was the COAPT trial. This is a study that was a parallel control and label trial in nearly 600 patients with moderate or severe FMR. Now, the study randomized patients either to mitral clip plus maximum medical therapy or maximum negative therapy. As you can see, one important point, they included 1,500 patients. Of these, the vast majority was not eligible. So 900 were ineligible, and only 600 were eligible. So when we look at the indication, possible indication for treatment, we see that we have a large proportion of patients who are not eligible. But the COAPT study basically showed a very significant effect in reduction in heart failure hospitalizations in patients receiving the device compared to patients not receiving the device. Not just that, the study confirmed the reduction of mitral regurgitation more than 2 grades, which suggested, although that was not a primary endpoint, and reduction in all-cause mortality and death and heart failure hospitalization, and an improvement in quality of life and exercise capacity. So basically, we had two trials, and with one trial showing the benefits in hospitalization, mortality, quality of life, and the other study showing no efficacy. Now, when you have two trials, one showing efficacy and one being neutral, you have to consider, first of all, if there are differences in the design that may explain the differences between the two different trials. And if we go and look more into deep details between the differences between the MITRA and the cohort study, we can see that there was patients in the cohort with a greater degree of regroup. Also, patients in the cohort had all been uptitrated to full maximal therapy, and they had a better success rate compared to the MITRA-HF. So if we go and look and divide patients with functional mitral regurgitation into patients with a severe and disproportionate mitral regurgitation, compared to when we basically look at the effective regurgitant orifice area in the left ventricular diastolic volume, and then those with a mild to moderate, but still within the group of severe and proportional mitral regurgitation, we can see that probably in those with mild to moderate mitral regurgitation, we tend to have less of an effect, whilst we have an effect in those with severe and disproportionate mitral regurgitation. Now, in between the today and what happened with MITRA, the FAR, and the COT study, we had the EACTF's guidance for the management of valvular heart disease that basically suggested what was already into the ESC guidelines, and they said that the treatment of with catheter has a low degree of evidence. Now, we know that probably that depends on the choice of patients. Another type of device that is still that is used and still under testing and has been tested is the Cardion device. This is completely different approach. It's an approach through the coronary sinus where this gets implanted and induce a reduction of the mitral orifice, and therefore reducing the regurgitation. It was tested in a study that reduced FMR, that included a small number of patients with a 2-to-1 ratio, 3-to-1 ratio, and was conducted between Europe, Australia, and New Zealand. And the study was mostly aimed at demonstrating the efficacy of this treatment on regurgitation rather than on clinical endpoints, and demonstrated that there was a change, a significant improvement in the regurgitant volume, and with a 22% in the treatment group, and there is an absolute difference in 10 milliliters. Then, similarly, there was a significant effect on left ventricular and diastolic volume with a significant difference of 16 milliliters. And that was associated with much less, with some increased risk of death and MI in the treatment group. There are some suggestions that some of these events may be related to compression of the coronary sinus, but that is something that is still to be tested and we have to look at the efficacy. So today, where do we stand with the functional mitral regurgitation? Probably we have to follow a different type of an approach that is more clinically based and also based on the evidence we have so far. So first of all, when patients are symptomatic with mild to moderate regurgitation, there is a need for an early referral to the heart team. Then of course, if there is CRT, that should be implanted whenever it's indicated. Of course, then we have to look at the life expectancy, because if it's less than 1 year, then patients should go into palliative care. If there's coronary artery disease requiring treatment, then there's a need to assess the surgical risk, and if it's low, CABG involve surgery. If it's high, probably to PCI, and if symptoms persist and there's a severe mitral regurgitation and the QUAT criteria are fulfilled, then a transcatheter mitral valve repair should be indicated. In those patients that do not fulfill the QUAT criteria, you can always think of a transcatheter mitral valve repair, but in very selective patients where you may believe that the benefit will outweigh the risk. So we're still in an evolving phase. We know that medical therapy is not entirely effective. That we know that in patients that fulfill the QUAT criteria, then there is an indication for the use of MitraClip. Other devices are coming. We have to see what is the efficacy, but I would say that that there is a good future for these interventions, and probably in the future we will have more evidence from of MitraClip and evidence from devices. Thank you very much.
Thank you very much, Dr. Rosado. It's very clear. And do you mean that if you have a patient with moderate severe mitral regurg and you control the medical treatment, you keep him on medical treatment? You shift the device or surgery if the patient is not controlled?
Yes. Yeah, I think first of all, we need to optimize whatever we have in terms of medical therapy. Of course, if with the optimized medical therapy, patients still have a moderate to severe FMR, especially in those patients where we see that in a few months they tend to have an increase in left ventricular diameters, or where they are very symptomatic despite the full medical therapy, then the percutaneous strategy should be pursued. But also, we always need to investigate the possibility of underlying ischemic heart disease, because surgery, if ischemic heart disease is there, is still an option.
Thank you, Dr. Lozano, for this clear presentation. My question is about severe mitral regurg in the acute setting. What are the main differences you think in the algorithm of management from the patients with severe chronic mitral regurgitation?
I think the acute is completely different, and Ovidio Fiancetta that spoke just before me is a very expert in this area, and whenever we have an acute event, we in order to, the problem is that when it's acute, often is due to a rapid cord rupture, and therefore the transcatheter repair is often suboptimal. So it's if there's a need, probably surgery is still the best option. But I see Ovidio that probably wants to comment on that.
Professor Rosano, thank you very much for your excellent presentation. In the Proof Heart Failure trial, there was a favorable effect for sacubitril valsartan on reduction of mitral regurgitation. So in the era of new drugs which have a favorable effect on remodeling, like SGLT2 inhibitors, drugs which are antifibrotic, sacubitril valsartan. So do you think that in the era of these new drugs, the need for mitral valve intervention in patients with heart failure will be much lower?
I think that we need to be more careful in selecting our patients. As you pointed out, sacubitril valsartan and the SGLT2 inhibitors are very effective, but also all medical therapies are still effective and underused. So first of all, we need to uptitrate and get to the guideline-directed therapy. If despite that our patients still have fulfill the OAT criteria, then we should think at the mitral clip or whatever intervention in the future. But unless we have any further proof of strong efficacy, I think we should always prioritize medical therapy.
Thank you very much, Professor Rosen. We are appreciating your great contribution to the conference, and we are looking forward to seeing you in person in the future. Thank you very much.
My pleasure.
Thank you. Closing this session, I have to welcome Professor Hassan Andil, Professor Muhammad Abdel Ghani, Professor Ayman Boumagdi online. So thank you very much for joining us in this very important session. And before closing the session, I'd like to thank my co-chairman, Professor Husam Hassan, Professor Muhammad Stiaha, Professor Jamil Al. Thank you very much. Now we will move to another session, which is AstraZeneca product arena with Professor Peter Sigorovich, who joined us in the first session. Past president of the Heart Failure Association of EGYHF Cardiology, Professor of Cardiology, Heart Failure Center, Medicine and University of Belgrade, and President of the Heart Failure Society of Serbia, and the current Vice President of the European Society of Cardiology. Professor Peter.
Yes. Thank you very much.
Do you hear me?
Yes, I hear you, I see you.
Okay, great.
So let me share the screen with you. Could you see my slides?
Yeah.
Okay, so thank you very much for the invitation once again. It is extremely important for us, and I see, because I was almost whole afternoon with you, that as you will say, as usual, the Egyptian heart failure working group is discussing the most important, most up-to-date, and mostly clinically relevant let's say, therapeutic aspects, but also diagnostic and pathophysiological aspects of the heart failure. As you know, Heart Failure Association of the ESC, and I may say that we are very happy to have Professor Magdi Abdelhamid as a member of the Heart Failure Association board. Is paying special attention on the new therapeutic options in heart failure. In 2020, we had a few position papers which was dealing with these new therapeutic options, and one of those is SGLT2 inhibitors in heart failure, behind we have this glycemic control, in which we clearly emphasize that dapagliflozin and SGLT2 inhibitors could be considered in the treatment of patients with HFrEF, with and without diabetes. What is also very important is that we had the addendum of this paper, which was published 3 days ago, which is giving further insight of the Heart Failure Association on these exciting treatment options. Obviously, 2019 2019 European Society of Cardiology Congress, we are all excited to learn that the EGYHF is positive. And just looking at the demographic and baseline characteristic of those patients, we understood that this is a typical heart failure patient we have and we are encountering every day, which means that those patients, and as you see, most of the patients did not have type 2 diabetes, and the rest had diabetes, were typically seen by the heart failure cardiologists in the countries all over Europe. What I would like to underline here is that the level of HbA1c was different, and you will see when we will analyze the result in the few minutes that is especially challenging are the cases with prediabetes with HbA1c between 5.7 and 6.5. The results were extremely positive, extremely well received and excellent. And you can see that the primary endpoint of cardiovascular death or heart failure hospitalization as well as urgent heart failure visit were reduced, and the relative risk reduction was 26% with a number needed to treat of 21. Most of us was extremely excited when we see that therapeutic benefit was achieved as early as at day 21, meaning that drug is acting straightforward and is acting very early during its administration. Both components of the primary outcomes, worsening of heart failure event and cardiovascular death, were clearly reduced in the patient who received NAPA. 30% relative reduction risk for worsening heart failure event and 18% for cardiovascular death. Obviously, we were very much interested about the hospitalization for heart failure, and that was highlighted in several publications, and the importance of this fact is practically something which confirmed our suspicion from several years ago that GLT2, in this case dapagliflozin, should be used in the reduction of the hospitalization for heart failure. If we look at the different aspects of the long-term outcome, like cardiovascular death, hospitalization for heart failure, then death, together death, cardiovascular death or heart failure hospitalization, or death from any cause, they were all together reduced by the effect of empagliflozin. In no trials of the SGLT2 inhibitors before DAPA-HF, the results were not so robust and so clear-cut. A secondary endpoint of cardiovascular death or heart failure hospitalization was also reduced, adding to the overall picture that dapagliflozin is overall extremely efficacious in this patient. Besides acting on the long-term outcome, dapagliflozin was shown to improve the functional capacity of those patients, increasing their functional capacity with more than 5 points of the KCCQ questionnaire. So it is important to highlight that besides the improvement in the long-term outcome, the patient also felt good, and they also felt good very, very early. Obviously, the positive effect on the renal function, which was also demonstrated in the DAPA-HF, and which showed that 10 milligrams of DAPA were practically acting on the study. Obviously, all-cause death is very much reduced, 17% of relative risk reduction. This is very important parameters, but it goes together with everything which was shown in the slide. So in the study showing that these results are probably all going with the same trend of the overall reduction of mortality. Even more, and for the pleasure of the heart failure physician, the safety profile of the DAPA agent was excellent, with side effects very close or even better than placebo. Once again, the hypoglycemia and diabetic ketoacidosis were definitely proved not to be side effects in the application of DAPA-HF. Therefore, the summary of the DAPA-HF gave us the possibility to say that we have a safe once a day medication which does not need the, any kind of up-titration with excellent side effect profile, which acts very early. And I think that no heart failure physician will ask for more. Obviously, the key for good clinical practice is to find the best selection of the patient, starting and giving 10 milligrams daily, and pre-initiation consideration, prescription, and long-term continuation goes within what is considered to be the best multidisciplinary care for the heart failure patients. It is interesting, and I pointed out earlier, that dapagliflozin reduced the incidence of new onset diabetes in population without diabetes at baseline. This preventive effect of dapagliflozin needs to be further explored, and this line of evidence is extremely important, because if this finally be considered as a fact which we can accept, then the armamentarium and also the spectrum of the patient we have will be endless. Dapagliflozin was extremely effective in any of the background glucose lowering therapy, and this is also what we need to teach our colleagues, diabetologists, but also some of the cardiologists, that this is not diabetology drug, and this is also not the drug which is only regulated HbA1c. But this drug is exceptional because this is one of the first drugs which is practically able to prolong the life and decrease the complication in the patient with diabetes. The question of the cost effectiveness, and you can see that the analysis from the UK, Germany, and Spain clearly demonstrated the incremental cost and benefit of applying dapagliflozin are definitely on the side of these agents. And if we take everything into account, especially the reduction of the heart failure hospitalization, then we can clearly see that this drug is extremely cost effective. Obviously, there is a big controversy about the efficacy of the drug in ischemic and non-ischemic cardiomyopathy, ischemic and non-ischemic heart failure, but the drug is effective in both entities. It seems that it is slightly more effective in non-ischemic cardiomyopathies, but it is also opening one very interesting field for us, trying to go deeper into the etiopathogenesis of diabetic cardiomyopathy, like a particular entity. If we compare DAPA-HF and emperor in the reduced trial, which appeared recently, we can clearly see that both drugs are effective, that both drugs are, the effect of both drugs is directed to the same direction. However, when it comes to the cardiovascular death and all-cause death, which may be also discussed about the power of the study to achieve this as a statistical parameter, it seems that the dapagliflozin was much more effective. At the end, ladies and gentlemen, we are discussing, and I see that there is a lot of things which were discussed here about the role of SGLT2 inhibitors, about the role of sacubitril valsartan, then ranibizumab, as well as omecamtiv mecarbil, which is going to be presented soon at the American Heart Association. I think that to some extent, the heart failure guidelines 2021 will give us the direction. But I also think that we need to know to deep the information about this drug, and then give all these drugs at a different time frame in the developing of heart failure, trying to do what we mentioned several times here, personalize and precision medicine for every of our heart failure patients. Thank you very much for your attention.
Thank you very much, Professor Peter, for this excellent presentation. Let us to focus on some important points regarding EGYHF and the use of SGLT2 inhibitor in patients with heart failure, which is practical tips for using SGLT2 inhibitors, because this is very important for the physician when considering the new drugs, especially when he considers the use of drug for non-diabetic patients. So he's asking for the risk of hypoglycemia, the risk of diabetic ketoacidosis, the risk of genital infections, how to protect patients before giving the drug, when to start, when to do monitoring for kidney function, when to consider to stop the drug, what to do when the patient develops acute decompensated heart failure and being hospitalized. So all these important issues are practical, important points. Should you highlight these points?
Of course. So you mentioned the whole medicine, and I will start from the beginning. First, let's turn our attention to the complications, side effects. The drug SGLT2 inhibitors, but in this case, dapagliflozin, has an extraordinary positive side effect profile. You mentioned ketoacidosis and hypoglycemia. It is probably the fate of us cardiologists to be the promoter of these drugs, and therefore the cardiologists should know that not hypoglycemia nor ketoacidosis are a problem at all. So we show that in the both big risky trials, and it is very important for us to know that we can give this drug without being afraid of these two side effects. As far as the genital complications are concerned, these two, they are more frequent, but in the last study, we were able to see that when the patient is advised to talk about the hygiene more than before, and when he was able to hold proper hygiene, that this is not a problem which can bother him to the higher extent. On the other hand, we should look at the big picture, and also we should look at what is important for the patient. And for the patient, it is important to previous knowledge what kind of drug he has. This is the drug which prolongs life. which is preventing heart failure hospitalization, and it is at the level of the drugs we are giving in basic treatment therapy of heart failure. And therefore, I think that the side effects, and this is a big advantage of those drugs, should not be seen as a problem. However, if you look at the clinical possibility of, for instance, when you are going to use this drug, it seems that the very early effect of the drug, which is 28 days as far as the dapagliflozin and 12 days as far as the empagliflozin is concerned, looks like a particular and exceptional advantage of SGLT2 inhibitors to skip over the titration of the other drugs, to give them very early and to not use any kind of thinking about uptitrating other drugs, but giving very early SGLT2 inhibitors for the sake of survival of those patients. So what else did you have in mind? And we can discuss one by one of these practical topics.
In patients who develop acute decompensated heart failure and being hospitalized in heart failure function class 4.
Yeah, so that is, there is some of the studies which were conducted, but they are conducted only in a small number of the patients. And it is for this moment, they are not considered to be the drug which should be given to acutely decompensated heart failure patients. They are considered that they can be used when the vulnerable phase of the patient is gone, and when he has a possibility to get into the stable phase, in whom the patient should have a stable therapy in terms of introducing the new drugs like SGLT2. So it was EMPA acute heart failure drugs, but the primary point in this study on about 100 patients was not positive, but it was improvement in 6 months rehospitalization. But this needs to be seen and confirmed in the bigger number of the patients with better defined
files.
Hello?
Hello, Dr. Victor. We missed you for.
Could you hear me now?
Yeah. We are hearing you well now. Okay.
Okay, good. That's always the risk with online contact, that you can lose the contact, but it's get back very fast.
Yeah, no problem. So how to monitor kidney function after starting SGLT2 inhibitor? After 1 week, after 1 month?
Thank you very much. That is a very important question. First of all, as we pointed out, and what is excellently shown in DAPA-CKD, the kidney function is very much improved by the use of SGLT2 inhibitors. What that means? That means that these drugs are preventing the progression of the kidney dysfunction, both in patients with diabetes and the patient who does not have diabetes. However, what it should be said, and that your question is extremely important. There is an initial decline of the kidney function, which is lasting around 3 to 5 days, after which the kidney function is improving and stay steady at the level of the improvement. Therefore, SGLT2 inhibitors are the rare drugs within the family of the drugs given to the heart failure patient, which has a possibility to maintain or improve the kidney function. As you know, the interaction between heart and kidney is very important in the patient with heart failure, and even more if the patient is New York Heart Association class 3 or 4. The kidney function is of essential importance because by protecting the kidney and improving the kidney function, we are able to halt the development of the heart failure and improve the functional status of the patient.
A final question. Are you considering the results of EGYHF and the Emperor reduced are concordant? So it's a class effect and both the studies in terms of
I thought that you are my friend.
Yeah.
But what we can say is that we have two excellent drugs. The drugs who will change the fate of our heart failure patient. Both drugs are showing some of the similar effect. Obviously, we all know that the cardiovascular mortality and to some extent all-cause mortality was much better reduced in EGYHF. However, we are physicians. If we look at the whole picture, I think that we should be very realistic and see that this group as a whole has the effect which we did not encounter before in any of the other group of the drugs. However, is this a class effect? Should come to the question, what is really the class effect? Class effect means that several drugs of the same group have a particularly same correction, a same effect in one particular disease. And right now, we have no proof for that. And right now, we are waiting for the results or decision of the task force for this is the ESC heart failure task force who is doing the guidelines, which will give us the final proof what level of evidence and what class of evidence they are going to give to SGLT2 inhibitors. Having in mind what we already have, and having in mind what is the reality, I think that it will be very hard. And I think it will be something which will change the algorithm of the treatment of the heart failure. However, one important question remains. With such drugs, in the drugs which definitely alter the development of the heart failure to the higher extent in a positive way, how we are going to approach the widening of the spectrum of the patient, of the doctors who are prescribing the drugs. Because by definition, this is drug given by the diabetologist. However, also by our understanding and our enthusiasm, and I was lecturing about SGLT2 inhibitors all over the world, I can say that cardiologists are much more prone to take the role of giving this drug to their heart failure patient than the diabetologist. Therefore, this is the question which should also be answered by our pharmaceutical companies who are producing the drugs. But I think and I believe that at the end, these drugs will be the inherent part of the treatment of the most patients with heart failure.
Thank you very much, Professor Peter, for these elegant presentations and excellent and great discussion for practical tips related to SGLT2 inhibitors and how to implement the results of the new trials in the daily practice regarding management of patients with heart failure. And we are appreciating your excellent contribution to our program today. And thank you very much, and looking forward to seeing you in Egypt when life is back to normal.
Thank you very much, but let me say just one important thing. You remember what it was said in famous film Casablanca, movie Casablanca, when they say this is just the beginning of one wonderful scientific cooperation. So European Society of Cardiology expect a lot from Egypt. And Egypt already gave to the European Society a lot, but we need to deepen the channel of communication. We need to improve this communication by involving more people, more young people, and also in the field of heart failure association. We have a big plan for this for your heart failure group. It is my extreme pleasure to see how advanced and how knowledgeable your cardiologists are.
Thank you very much, and we are appreciating the excellent collaboration of the HFA and the EC with the Egyptian Society of Cardiology. Thank you, Professor Peter, and see you later. Thank you. Bye-bye.
See you later. Bye-bye. Have a nice night.